The main point that I want to get across to you is do all of this before you wheel off to PACU, because you don't want to take, especially if your PACU is, if you're in a big OR, you're in a 30, 40 bed OR, and you're trying to go down, it feels like half a mile to get to PACU. You really want to make sure that your patient is exchanging before you start that journey, because you want to deal with everything in your own environment, in the OR, your anesthesia machine's right there. Deal with everything before you start making that journey to PACU. It will save you so much time and such a headache if something were to happen on the way there. Now you're in the middle of the hallway trying to break a spasm, or now you're in the middle of the hallway dealing with a patient who's apneic. You don't have the equipment that you need. So this just goes back to being prepared. Do what you can in your environment, not on the way to PACU where you don't have any equipment with you.
Hello, future CRNA. Welcome to CRNA School Prep Academy podcast. I have a very special episode lined up for you today, and it is part of our guest host series where I am bringing current SRNAs on the show for you as a guest host on the CSPA podcast. And my thought process behind doing this is I wanted you to hear from current students, a variety of current students who are at different stages of their CRNA journey, and really allow you to kind of step into their world and hear them talk about what it's like to be a current student dealing with things like difficult preceptors or different anesthesia topics, clinical topics, maybe even things like time management, stress management, things like that. I think these episodes are going to be gold, and I hope you enjoy as much as I always do hearing from current students. I know for a fact that the reason why CRNA School Prep Academy is where it is today, and the reason why I have learned so much, is from diving all in, listening to current students along with CRNAs share a wealth of information, and really kind of taking all of that information and kind of compiling it into kind of the system that we have created today. And I know that you're doing the same thing by tuning into the show week after week, developing your own method, your own strategy, and your own system for success. So I hope you enjoy these guest episodes. Let's go ahead and get into today's show.
What's up, everyone? I'm David Warren, and welcome back to this episode on the CRNA School Prep Academy podcast. I'll be your guest host today. And today we're wrapping up with our part 3 of Emergence and Extubation. If you haven't listened or seen the first 2 parts, go back and check those out. This might make a little more sense. Part 1 deals with deep extubations. Part 2 deals with awake extubations and kind of the variations that go with those techniques of waking a patient up. And today we're going to talk about some of the most common things that you might see post-extubation that would require your immediate attention. Today is a beautiful Saturday at the recording of this video. It's 70 degrees outside. I have the windows open and it's just lovely. So I hope your Saturday is going just as well as mine is right now. Today, we're talking about those post-extubation nightmares, so to speak, things that we would want to be aware of after we pull the ET tube out of the patient. So the first thing I want to mention to you is make sure the patient is extubatable. Make sure the patient is extubatable. And so like 80 to 90% of the surgeries that we do, you're going to extubate the patient, right? So you're going to extubate your lap choles and your lap appies and all of the typical general surgery things that we do, unless for some reason the patient can't come off the ventilator because they're not breathing or, whatever that may be. You may have to leave them intubated. But the vast majority, you will extubate in the OR. Now, I say that whenever you get to your specialty cases like neurosurgery, cardiac surgery, things like that, just make sure that the patient is extubatable. So just verify with a surgeon. If you're doing an open craniotomy for a brain tumor, just verify, hey, do you want the patient intubated or do you want me to extubate here in the OR? And the surgeon will just communicate, tell you exactly what they want. So just verify before you get to the end of the case, you haven't talked to anybody about it, you're trying to extubate the patient, just make sure that the surgeon wants the patient extubated or that the patient needs to be extubated. If they come to you intubated from ICU, typically, we won't extubate those patients. We'll send them back to the ICU intubated and let ICU extubate the patient whenever they want to. So just verify that the patient is extubatable. And then all of those things at the end of the case that we've talked about in the other 2 videos, make sure the patient, is pulling. If you're going to extubate the patient, make sure they're pulling good tidal volumes, they have a good minute ventilation, good respiratory rate. They're fully reversed from their muscle relaxant. Just make sure that they meet all those criteria to extubate the patient before you try to pull that tube. So just common sense type things. Now we're going to move on to some of the things that we might see post-extubation that we would want to be aware of. And the first of those is a laryngospasm. So a laryngospasm is essentially where the musculature that controls the vocal cord movement during stage 2 anesthesia, during the period of hyperreactivity, those muscles will kind of spasm and contract and slam the cord shut. And that prevents movement of air. And so essentially, whenever you have cords that are closed completely and a patient that is trying to breathe against a closed glottis, you can have negative pressure pulmonary edema, which could potentially be lethal to the patient. So you really want, that's kind of the main thing that we worry about during extubation. Now, you can get a laryngospasm during your induction, especially if you're doing a mask induction, say for a pediatric patient or even for an adult patient for whatever reason. You could get a laryngospasm during induction. However, it's most commonly associated with emergence and extubation, and that's kind of where we see that at. So again, going back to our first 2 videos, we really want to get the patient either through stage 2 before we pull the tube, or pull the tube when they're super deep, so they just go through stage 2 naturally. So you really don't want to pull the tube when they're in that stage 2 of anesthesia, period of hyperreactivity, they're breath holding, they're tachycardic, they have a nystagmus, their eyes are pointing like opposite directions, all of those things that would let us know that, hey, we're in that period of hyperreactivity, stage 2 anesthesia. We don't want to pull the tube now unless you want to deal with a laryngospasm. So that's kind of what a laryngospasm is, why we want to avoid it. So for our scenario, I think we've been saying we have like a 40-year-old who is getting a laparoscopic cholecystectomy. Let's just say for this particular scenario that we are going to wake the patient all the way up. And so this is kind of a common thread, honestly. We're going to wake the patient all the way up for whatever reason. We have reversed our paralytic. We have put in an oral airway. We've suctioned out really well. The patient's on 100% FiO2. She's pulling good volumes, and she has a good minute ventilation, good respiratory rate, not insignificant pain based on the vital signs we see and based on our ventilator settings. Most of the gas is blown off. She's at maybe like 0.2 Mac. And she is kind of coughing and bucking a little bit on the tube and trying to reach her hand up to pull the tube out. So at this point, it's safe to say she's probably fine for extubation. So we'll deflate our cuff, pull our tube out, and hold our mask on to see if we are exchanging with the patient. So we're holding our mask on, and kind of some signs and symptoms, some things that we would see letting us know that the patient may be having a laryngospasm would be things like breath holding. So she's not moving any air at all. So typically after we put our mask on the patient, we're looking for fogging. So we'll see that mist in the mask, or we can look over at our monitor and see that there's positive end-tidal CO2. If you're having a laryngospasm, you're not going to see any of that. You're not going to see any exchange at all. The patient may be trying to breathe, but since they are trying to breathe against a closed glottis, there's no exchange of CO2 and oxygen. So you're not going to see any end-tidal CO2 on there, and you're not going to see any mist or fogging in the mask. But I'll tell you what you will see. You will see the patient trying to breathe. So you'll see them trying to pull with their accessory muscles on their chest. You'll see maybe some pulling here around the supraclavicular region. All of those things may be letting you know, hey, this patient is in spasm. And so those are the things that we want to watch out for. And that's why it's so important that after you extubate your patient, it's not just holding the mask, waiting for the bed to come in and move the patient over. It's truly after extubation, hold the mask and make sure the patient is moving air. So we'll look at the mask. Are they fogging? Are they misting? Do they have chest rise and fall? Do they have any pulling or tugging in the supraclavicular region? Are they exchanging? Do you see positive end-tidal CO2? If you don't see positive end-tidal CO2, just make sure you have a good seal, because chances are maybe there's a little leak around the mask. So just make sure you're doing either a two-handed mask and a jaw thrust, and you have a really good seal. And that way you can see if you have positive end-tidal CO2. So let's say we've done all those things. We don't see any positive end-tidal CO2. The patient's tugging in the supraclavicular region, and they're not exchanging any air. So at this point, it's reasonable to kind of go down our pathway of treating a laryngospasm. And kind of the most common reason that we would see a laryngospasm is there's something irritating around the glottis. And usually before we extubate the patient, it's the ET tube. But when your ET tube is in place, those cords can't snap shut because you have a tube there preventing that. So you have a secure airway. So even if they are in a laryngospasm, when the tube is in, the cords aren't going to close because there's no way for them to close because there's a tube there. However, all bets are off whenever the tube's out. The cords will snap shut. So after the cords have snapped shut, usually it's because there's some sort of irritation in the airway. So the first thing you could do is suction the patient out again. So run your yonker down the throat, suction out really well and pull back out, and then do some positive pressure. So we'll do either hold the mask on with one hand, crank your APL down and provide some positive pressure. So typically we'll crank our APL down to like 50 and then provide some good positive pressure. Or you can do a two-handed mask, hold a really good seal, crank your APL to 70 and hold it there. And then you can have the nurse come over and squeeze the bag for you if you don't have a second set of hands. Or if you're getting a good seal, you could hold the mask yourself, crank it down a little further and provide some positive pressure ventilation. So really suctioning out, positive pressure ventilation, those are kind of the first two things we would think of in treating a laryngospasm. And so the positive pressure, I would say, at least in my practice so far, which has only been almost a year as a nurse anesthesia resident, positive pressure will take care of it. Usually positive pressure a couple times will break that spasm, and then you're good to go. And then turn your APL back to open, hold the mask and see if you're exchanging. If you're exchanging, then you know you've broken your spasm. And then let's say that doesn't work. Let's say you try positive pressure ventilation, not working. The next step would be to do what we call a Larson's maneuver. And that's where you're holding a two-handed mask and you're using either your index fingers or your two middle fingers here while you're holding the mask on, and you want to press really hard on both sides in what we call the laryngospasm notch. And it's just behind the earlobe here at the corner of the mandible. And you really want to push really, really hard right there, both sides, as you're holding that mask. So push, hold for about 3 seconds and then let go. Push, hold for about 3 seconds, 3 or 4 seconds and let go. And then do it again. Usually do it 2 or 3 times. And I'm talking about pushing hard. Put some good pressure in that notch there. And usually that will break the spasm if the positive pressure did not. And so after you do that, again, hold your two-handed mask, see if the patient's exchanging. At this point, doing what we call the Larson's maneuver, pressure in that laryngospasm notch will usually break the spasm. If that doesn't break the spasm, then we would need to kind of go down our deepen the anesthetic pathway. So we would want to deepen the anesthetic. And again, turning on the gas isn't a good way to deepen the anesthetic because if they're in spasm, their cords are snapped shut. The gas can't get to the lungs to get to the brain anyway. So we would use something like propofol. So this is why we always have an extra stick of propofol handy. And usually we give about 1 mg per kg of propofol, or anywhere from like 50 to 70 milligrams for an adult. So if you're still in spasm now, and you're not exchanging at all, so no entitled CO2. At this point, hopefully you've pre-oxygenated, or I say pre-oxygenated the patient. This is during emergency extubation. Hopefully you've, in quote, pre-oxygenated the patient, meaning before you pull the tube, you put them on 100% FiO2, so their end-tidal oxygen, is like 80 to 90%. So that's going to buy you, in a normal non-obese person, like 7 to 9 minutes of apnea time before they start to desat. So you've got theoretically 7 to 9 minutes in a normal person, not significantly obese, no medical problems, somebody that doesn't have significant respiratory pathology. You've bought yourself a lot of time to deal with this. And that's why we turn our FiO2 to 100% before we extubate, because we really want that FRC to be filled with 100% oxygen and not nitrogen, so that if something like this happens, you've bought yourself some time. You've bought yourself 5 minutes. You bought yourself 7 minutes of apnea. So they're still 100%. You've bought yourself a lot of time to deal with an emergency like this. So that's why we put the patient on 100% FiO2.
Well, hello, future CRNA, another daily dose of inspiration along your CRNA journey. This success story starts with I just wanted to post this as a reminder that you can get into CRNA school even with a low GPA. I would always see people posting their stats with a high GPA, community service, every certification, asking if they had a shot at school, and feel so discouraged about my own application. I got into school with my first degree GPA of a 2.98 with C's in most of my science classes and completely failing out after my freshman year. My nursing GPA was just a 3.4. I never really took any classes, only microbiology, general chemistry as prerequisites for nursing school since I had a previous C's. My science GPA is still probably way under a 3.0. The only certification I have is a CCRN. I have nothing special under my belt like committees or community service. I was just flat out honest with my grades in my interview and emphasized my passion and dedication to becoming a CRNA in my personal statements. I hope this was helpful for someone because I know how it feels to see all the stats people post and feel that you will never make it because you don't have a perfect competitive GPA. You can do it. I just love this so much. Thank you, who you are for sharing this because this really truly does give so many hope. And hope is a powerful, powerful thing. If you have hope, you have belief. If you have belief, you take action. So thank you so much for sharing this. You do not have to be perfect. The road to CRNA, while it's going to be full of ups and downs, and yes, with these kind of statistics, you may face rejection. More than likely you will. But that should be the expectation, and then you should try to find ways to grow and spread your reach. Try out different programs. You never know unless you try. And, this student gave themselves a chance, even though they weren't sure if they'd make it. And I guess I wanted to also point this out because recently we launched a CRNA Guarantee program, which I'm so thrilled about. But you guys, it was really hard to pick students, and I saw so much in all these students, and I wanted to accept every single one. But we couldn't do that. And I've said it, but I want to say it again, especially if you're listening to this podcast and that was you. I believe in you. I really, really believe in you. And I hope you believe in yourself to give yourself the gift of trying. So with that, I'll leave you guys something to ponder and let's get back into the show.
So after we have deep into the anesthetic, usually that will work. So get the patient deep again to where those muscles relax, and then you can exchange. And at that point, let them wake up again, and hopefully they will be over that spasm. Now, let's say that doesn't work. So we've deepened our anesthetic, we've given propofol, say we've given 70 of propofol, the patient's still in spasm. You could choose to deepen it more. Maybe you could give another 100 milligrams of propofol, really put the patient out. These are getting towards intubating conditions without paralytic. Give them another dose of propofol, and then see if you can break that spasm. All the while, we are providing positive pressure ventilation, trying to break that spasm, and we're putting pressure in that laryngospasm notch. So we're doing Larson's maneuver, all of that to try to break the spasm. Now, I will say I've never gotten to this point of not breaking a spasm. I'm sure that happens. It's just not super common that you have to get to this point in the pathway to break the spasm. At this point, you should have already called for help. Get another set of hands in the room to help you kind of troubleshoot and go down that pathway of breaking a now significant spasm. So usually, like I said earlier, if you do have a spasm, it's easily broken with some positive pressure ventilation or some suction or some Larson's maneuver. That breaks like 90% of spasms. If you get to the point of where you're having to deepen the anesthetic and you're giving a bunch of propofol and they're still in spasm, the next step would be to give a very small dose of succinylcholine. And this is also why Sux is one of our emergency drugs, not just for RSI, but for laryngospasm. So we would give anywhere from 10 to 20 milligrams of succinylcholine IV to try to break the spasm. And that's just enough relaxant to make those muscles relax in the airway that you are out of spasm and you can exchange air. It's not enough muscle relaxant to completely paralyze the patient. So again, it's very important that we're not giving, unless you need to down the road, 100 milligram or 200 milligram of Sux. You're giving 10 to 20 milligrams to break the spasm. So half a cc to 1 cc of succinylcholine to break the spasm. Now, let's say we do that and that doesn't work. Now, you've tried everything you can. You've suctioned the patient. You've tried positive pressure ventilation. You have tried Larson's maneuver. You've deepened the anesthetic with propofol. You've given Sux, still not working. Now, the only other option is to re-intubate the patient, in which case we would give the rest of the sucks. So depending on, whatever weight-based dosing they have, usually 100 does the trick, 100 of sucks, and then give your 100 of propofol or whatever you've got left over, and then re-intubate the patient. Because remember, you've just given propofol maybe 2 minutes ago, 70 to 100 milligrams. So the patient is already out. You can safely give your sucks, follow it up with maybe a little more propofol, and then re-intubate the patient, because that level of muscle relaxant will relax all the muscles in there, and you'll get a perfect view. Hopefully they weren't a difficult airway. You'll get a perfect view of your cords when you go to DL, and you'll re-intubate the patient. And at this point, I would let the patient wake all the way up to where they are trying to pull. They've opened their eyes. They're like leaning up in bed, trying to pull the tube out themselves. Essentially, let the patient self-extubate. And you shouldn't get another spasm. And if you do get another spasm, you kind of go down the same pathway again, maybe leave them intubated. So that's kind of how you deal with a laryngospasm. After you've broken the spasm, let's say the positive, like 90% of them do, let's say the positive pressure works and the Larson's maneuver works, you start exchanging again. Hold that mask on, make sure they're going to breathe for maybe a minute or two, and make sure they're not going to respasm. Usually once they've passed that stage 2 of anesthesia, they're not going to spasm again. Put a non-rebreather on, tilt their head to the side, open their airway, all the things that you would normally do. Make sure you see misting and fogging if they're exchanging, and then you're good to go to PACU. So that's kind of how you deal with one of the most common problems we see, a laryngospasm. That's kind of how you troubleshoot that and deal with that. Another thing that we see post-extubation is like a post-extubation obstruction. And usually that's from soft tissue in like the neck, mouth region collapsing back because they're just not fully awake yet. So again, putting that oral airway in really goes a long way, especially before you extubate the patient. Sticking that oral airway in, and then after you extubate the patient, holding that mask on. I always start with a jaw thrust. So do a good jaw thrust, see if they're exchanging. If they're exchanging there, go to just a chin lift. And if they're still exchanging there, then just hold the mask on with just a couple fingers and make sure they're still exchanging. And then you know that they are not going to obstruct as you're wheeling down to PACU. So holding that mask on, again, without any support before you leave the OR, will give you a very good inkling as to whether or not the patient is going to obstruct or not. If they are obstructing, then go back to a chin lift and see if they're exchanging. And then if they are exchanging good there, then you'll know after you put the non-rebreather on, hey, I need to go to PACU holding a chin lift so the patient's not apneic and obstructing all the way to PACU. And I have seen patients still obstruct with a big, like 100 millimeter oral airway in place. So just know that just because the oral airway is in place, they still can obstruct. At that point, you could also consider a nasal trumpet. So slide a nasal trumpet in, see if that does anything for you. Again, the main point that I want to get across to you is do all of this before you wheel off to PACU, because you don't want to take, especially if your PACU is, if you're in a big OR, you're in a 30, 40 bed OR, and you're trying to go down, it feels like half a mile to get to PACU. You really want to make sure that your patient is exchanging before you start that journey, because you want to deal with everything in your own environment, in the OR, your anesthesia machine's right there. Deal with everything before you start making that journey to PACU. It will save you so much time and such a headache if something were to happen on the way there. Now you're in the middle of the hallway trying to break a spasm, or now you're in the middle of the hallway dealing with a patient who's apneic. You don't have the equipment that you need. So this just goes back to being prepared. Do what you can in your environment, not on the way to PACU where you don't have any equipment with you. So those are some of the most common things. By certainly no stretch are all the things that you'll see, or all the things that could go wrong post-extubation. But those are some of the most common things that you'll see. So laryngospasm, how to deal with that, how to assess it, how to diagnose it, how to treat it. And then like a post-extubation obstruction, again, just make sure the patient's exchanging air before you leave. Those are two of the most common things that we see post-extubation before we take the patient to PACU, and how to recognize it and how to treat it. If you have any questions, comment below. Let us know what they are. I would be happy to answer those for you. Thank you so much for listening to this video on emergence and extubation. Again, if you haven't listened to the other 2 videos, go check those out. This video might make a little more sense after you've listened to those 2 videos. Thanks again so much for watching, and I'll see you next time.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.